Good afternoon and welcome to the Zero Suicide Healthcare webinar. Today's discussion is on restorative, just, safety-driven culture, and it will be with the pioneers of this approach in Australia, Dr. Catherine Turner and Ms. Diana Grice from the Gold Coast in Queensland. I'm Sue Murray. I'm from the Zero Suicide Institute of Australasia, and I'm pleased to be hosting this discussion. I just wanted to set the scene for why zero suicide in healthcare is such an important approach and an important framework. Its focus is really to support the health services or health systems take a continuous improvement approach when working with people who experience suicidal behaviours. These are just some of the reasons why we're promoting this approach. The Global Burden of Disease report suggests that figures for healthy life lost as a result of suicide, when we translate the figures to the Australian context, it shows that there's in the vicinity of 140,000 years of life lost annually to suicide. This statement is really the foundational belief on which the zero suicide framework was built. And a restorative, just and safety-driven culture is integral to its success. And we really must see health system leaders foster a culture in which there is a belief that a suicide or an attempted suicide is an avoidable outcome of care in a modern health setting. And then finally, our fifth mental health and suicide prevention plan calls on health services to seek to achieve zero suicide for people within their care. So that just gives you a snapshot of a few reasons as to why we need to be thinking about and planning for the implementation of zero suicide healthcare. It's my pleasure now to hand over to our experts, Dr. Cathy Turner and Ms. Diana Grice, to share with you their experience in implementing zero suicide healthcare within a just restorative culture. Thanks, Cathy.
Okay, thanks very much, Sue, and hello to everyone. Thanks very much for joining us this afternoon. I'd like to start by acknowledging the traditional custodians on the land on which we meet and everyone is meeting currently, and pay respects to elders past, present and emerging. This afternoon we're going to try to cover a few issues, talk a little bit about the drivers for why we did this work, and two significant pieces of work that sort of came out of this, which was a staff support program and reviewing how we review incidents and changing the way that we approach incident reviews. We'll talk a bit about just culture and how that is different from the more traditional just culture is different from restorative just culture, and how we've attempted to embed restorative just culture. And then we've got some results of some of our staff survey, which I think is really encouraging and interesting information as well that we wanted to share with you. So it probably has been, even before we embarked on zero suicide, we had some concerns about incident reviews, and we felt that there was a better way of doing this. But really, deciding to introduce zero suicide, we were concerned about the risks associated with the zero word, and that there were concerns that it could exacerbate or create a blame culture. So we saw that really embedding a just culture approach was an essential element from the outset. So the concerns that we did have about learning and improving included the concerns about a culture of blame, the concerns about the level of engagement of staff in the learning process and the quality of reviews following incidents, particularly from RCAs that were being done, the quality of recommendations, and also the consistency of support of staff following incidents, and the concerns about the impacts on staff of losing a patient to suicide. So we had a look at lots of evidence of models of incident reviews, evidence of models of just culture. We looked at the literature around the impacts on staff, and engaged in roundtable discussions with a range of stakeholders, including experts regarding just culture. And really importantly, we engaged the executive and the board, in addition to all of the service and our lived experience workforce. And there were there were two large pieces of work, as I mentioned, that fell out of that. One was around how do we better support staff, and the other was how do we improve the way that we learn from incidents. And really integral to all of that was how we engage consumers and carers in that process. So I'll hand over to Diana, who's going to talk a bit about the support staff project and work that's come out of that.
So, hi everybody, Diana Grice. I'm the Director of Nursing for Gold Coast Mental Health and Specialist Services, and it's great to join you this afternoon. I think I'll get that right. So, as Kathy said, this was a very specific piece of work that came out of our journey to zero suicide. What happened was when Kathy and I went out and talked with staff about what we were looking to, for them to join us in terms of achieving, we had a conversation around what is it like to be involved in an incident and the impact on individuals. And Matt Walsh, who is our suicide prevention coordinator, and myself went back out to teams to talk more specifically about that piece of work. And so we visited every team across our service to talk about the impact of an event on them as individual practitioners and on the service as a whole. And as we know, healthcare staff face unexpected stress every day during the course of caring for consumers. And so when we went out to staff, what they told us from our focus groups very much was that support is not provided in a way across our service at that time that was consistent, that it was very dependent on who the person in charge of the shift or the event was, who other participants were. They told us that they needed a very timely response and they wanted it to be reliable. They wanted it to be immediately or as close to the event as possible, and then they wanted follow-up following that. They didn't just want a one contact. And they also told us that they would like to be part of the support process for their colleagues. They overwhelmingly said to us that they needed the person who was responding to the incident to say or to ask them, "Are you okay? How can we help you?" and not the traditional, "What happened and how did this happen?" And I think that was really a moment for me, particularly where I thought we often go into that mode of just having to gather the facts, which of course we have to do anyway, but right at that immediate time they really wanted that compassionate, empathic response, which was, "Are you okay? How can we help you?" So what we did after that was formed a small working group and we went out to the literature to see what was available, and we came across the second victim phenomenon, and people may well have heard about that by now, and that really the term was coined by Dr. Albert Wu back in 2000, and it really said that despite best intentions, adverse outcomes will occur. That there are almost always two victims, and one of those, of course, is the consumer or the patient, and the second victim is the healthcare provider who was involved in the incident, who feels in some way responsible and is emotionally traumatised by what has happened. And that looking after the second victim is absolutely essential in order to bring about a just culture within an organisation. That employee support, particularly peer support, so colleague to colleague, is one of the strongest predictors of good psychological outcomes for staff. So we also in the literature found Scott's model of peer support, which is an intervention specifically aimed at second victims, and Susan Scott is a nurse from the US. It was developed for healthcare, and it prepares individuals to provide non-judgmental, confidential emotional support to their peers. So we've really done a lot of work around Scott's model, and we'll come to that in a couple of slides. The other elements that we looked at and we've taken into our program are the GRACE model of compassion and social resilience framework, and Denham's 5 rights of the second victim. So there's a lot of information available around different models that you can use, and we also use psychological first aid, which is the gold standard for crisis intervention, and it's used, as most of you will know, it's used in recovery following disasters, but it's based on empathic listening, and it's great in this sort of environment. So the trajectory of stress responses, and I can hardly see that even though I've got my glasses on, but basically, I'll have to read from my sheet, sorry. Even then I can't see it. So there's an unexpected cause or event at the beginning. Then there is the response from the second victim response or the individual's response. Then the next box is the organisation's response to this. And it's at that point you want to see the organisation make a meaningful response. Otherwise, the clinician's recovery can be impacted. So you either have someone who, in the red box, I think, that they basically drop out of the workforce because they can't recover from it, or in the middle box, they're just surviving, or in the last, or the green box, they actually continue to thrive and be a really fantastic mental health practitioner or health practitioner. In terms of the Scott's model, and I think if you just want to click to the next slide, thanks, Kathy. Scott's model is 3 tiers. The first layer, and I've got 60% there, that's most of the response is that first response, and that is about building a culture within your organisation where everybody understands the impact of adverse events on their colleagues, that we look after each other, that we're kind to each other, that we bring back some of the practices around making sure that everybody's okay before they finish shift, some of those simple things that perhaps we've lost over the years. So that's a foundation. The middle tier, tier 2, is where we provide the always there response, and I'll come back to that in a minute. And then the top tier is really more of those professional services, perhaps your EAS, Employment Assistance Program, counselling, referral to the GP, those, or recommendations that you go back to see your GP, those sorts of strategies. Tier 2 is where we make what we call our always there response. That's very much about your colleagues who we have trained in psychological first aid, taken them through the program, they do simulation training, and then they become an always there responder. That's where we make the biggest impact. We've talked about 2 responses within that, so just to the next slide, thanks Kathy. So we've seen 2 responses as part of our intervention, what we've called locally our hot response, and that is about that immediate response following an adverse event, and that we want that to be reliable, that the process will be that the person is seen as close to the incident as possible, certainly the next working day. Then there is a follow-up from the same responder 3 days later, and then again 10 days later. Now, I need to be really clear, this doesn't take away the obligations of your line managers to look after their staff and be engaging with them and making sure that feeling well supported as well. This is in addition, this is colleague to colleague. And then if they need to, through the hot response, the responder may let the person know after those 3 touch points that they perhaps need to go on and see their GP or access another service. We also have what we call the warm response, and this was something that came from the working group, which was that by putting people's names of who are trained as responders, up on our local website, that people can just choose to pick up the phone or email a responder and say, I'd really just like to touch base with you because I might be struggling in the workplace today, or something else might be going on, and it is just a chat and a collegial conversation. So there's nothing formal about this at all, and it's self-driven. In terms of what contact we keep, we really only get the numbers of people that have, incidents that we've had, and the unit that the person or the team that the responder went to. We don't keep any other information, and that was one of the probably really important aspects of this, was being clear that this was different from a clinical review that will have to take place as part of good process and being a learning organisation. This is about colleague-to-colleague support. And the other thing that we did very deliberately was we didn't allow managers to be part of this response. So when we went out to people to be volunteers, because they do this as part of their workday, we were very clear it wasn't around managers. We've had a great response for people wanting to be trained, and we have AOs, we have all of our allied health professions represented, we have nursing and we have medical staff. So it's been a fantastic response from our staff where they've really wanted to get on board and provide support to their colleagues. So I'm going to finish by showing you the wee video that we developed to help promote this. And what we did was we went back to every single team that we'd gone to begin with to talk about what support do you need. We went back to them as a leadership group to say, you told us this is what we've done, and let's get on board with it. And they were really receptive, and we've had very positive feedback about the fact that we listened to staff and we were able to do something very tangible about it. So I'll leave you with the video, and then Kathy will pick up after that.
We're here through thick and thin, so why don't you pick up the phone and call us, 'cause we're always there. 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 We're always there.
Okay. So thanks for that, Diana. And we're very happy to answer questions. We'll probably continue on this section about learning from incidents and then answer anybody's questions at the end of that. Hopefully we'll make sure that we leave some time for questions. So I'm going to talk a bit about the work that we did around learning from incidents. So we know that cultural and organisational factors, as well as factors related to complexity of healthcare, are driving unacceptably high rates of adverse incidents in healthcare. And, there's a lot of evidence that in part, these are due to a culture of blame in the healthcare industry. And really that if we want sustained improvement in quality and safety, it will be significantly reliant on changing workplace culture. So I think if there's one message that I'd like to send is that culture and just culture is centrally important. It's not the bit at the side that you do, or it's not just about staff welfare, or it's not what you do when you get a chance after you've done everything else. It has to be central to what you do to create the foundation to make changes in the workplace. So we published a paper, which I think the link has been sent out, called Inconvenient Truths in Suicide Prevention and Why Restorative Just Culture Should Be Implemented Alongside a Zero Suicide Framework. And the inconvenient truths that we talk about are both suicide specific but also non-suicide specific. And, there's actually a lot, we have more than mental health within our directorate, and we use the same process for any incidents, suicide or other incidents, and we think that it's got broad applicability. But the sort of things that we were talking about is, one, the staff on the staff impact and second victims, but also the challenges with incident reviews. In suicide prevention particularly, we know that there's a fallacy of risk prediction. We think that somehow we can predict risk, but there's lots of evidence that we can't predict. And yet often reviews in the past have looked through the lens of, there should have been, the clinician should have been able to predict this somehow. But that doesn't mean that we can't prevent suicides through a systems approach. Hindsight bias, outcome bias, the complexity of the healthcare organisation that we're working in, and how the linear approaches to learning really fail to capture or recognise this complexity. And I'll talk a little bit about safety 1 and safety 2, and human variability and trade-offs, etc. And then clinician welfare, about working within a complex system where incidents are reviewed, they're not viewed through the lens of complexity. So I'll talk through some of those issues, because I think it is important to sort of think about, why we do need to do things differently, and then we can talk about how we do things differently. But what I found is that it is important to talk about the why, particularly if you want to bring about change in your organisation. Getting people to understand some of the drivers and the why is important. So safety 1 is, a really good foundation. It's the current paradigm. It's contributed significantly to quality and safety. It's enhanced through looking at human factors and latent factors. What it does is looked at, let's imagine what should be done, and let's ensure that work is done as closely aligned to work as imagined as possible. And it defines values through incident reporting. So it identifies deviations from work as imagined through linear processes such as RCAs. So it sees any deviations from that as rule violations, and it really focuses strongly on standardising care and reducing variation. And it really has a narrow focus on a lack of safety, as identified through the study of infrequent adverse events. So that's how we know if there's safety or not in an organisation, through those sort of relatively rare, severe incidents. So it's thought to be particularly useful in well-understood predictable systems. And there's lots, we do want standardised care, from the vast majority of our working lives, but we know that we've got much more complex systems that we're dealing with. So we know, so just touching on hindsight bias, we know that it's a complex issue and it routinely impacts incident analysis. If we're aware of the outcome, we tend to overestimate the likelihood and the ability of the clinicians to have predicted it. You just get such great insight into the fact that this event would have happened as soon as it happens. So it does tend to colour the evaluation of actions taken prior to an outcome. So you see, actions taken before a good outcome as good, actions taken before a bad outcome are often viewed negatively. And it's impossible to remove. We cannot prevent hindsight bias. We cannot completely remove hindsight bias. But perhaps we can mitigate it by, instead of taking a backward look from the incident, by having a look, constructing and understanding the mindset of people as they experience the events and unfolding, and why their assessments and their actions made sense at that time going forward. So outcome bias, we allow the outcome of an event to influence our response to it, or it's prevalent that we use outcome bias all the time. And it really represents a barrier to both safety and a sense of justice. So Marx, who talks a lot, who writes a lot in the traditional just culture world, notes that there's a need to understand the actions of staff rather than the outcomes that they produce, as reacting to the severity of an outcome may simply punish the unlucky. But what's even more important is that it allows unsafe actions to continue. So we focus predominantly on events with the worst outcomes. Poor practices or problems within the workplace that don't lead to a bad outcome, we don't notice or respond to. It's only once there's a bad outcome. So actually unsafe systems persist with the current safety one paradigm, whereas we need to look at things differently so that we're aware of what's happening and the unsafe situation that's happening, and that's where Safety 2 comes in a better way. So Safety 2 is switching the focus from preventing things going wrong to purposely enabling them to go right, and it can be complementary to Safety 1. So we don't want to throw out all the good stuff about Safety 1. It's a really good foundation, but we need to understand that the world is much more complex than that. So Safety 2 particularly looks at, it views variability as, so Safety 1 sees the variability as violations, non-compliance, deviations, whereas Safety 2 would say actually resilient symptoms require humans to adapt when the unexpected occurs. So variability is actually essential to maintaining a safe system at the appropriate time. So trade-offs occur, and one of the most significant is the efficiency thoroughness trade-off. And for our world, emergency departments, is a great example of where those efficiency thoroughness trade-offs. Because if we are not efficient, the whole system will grind to a halt, and that will be an incredibly unsafe system. But the risk is that we reward efficiency when we move people through quickly and when we get our neat targets right. There's a lot of reward for that. But what we don't know is with Safety 1 is that we won't know the problems with that and the trade-offs occurring with that until there's an adverse incident. With Safety 2, we need to be aware of, well, what are the trade-offs occurring? And when there's an incident, we always look through the lens of thoroughness rather than understanding that we need, there are often trade-offs that are occurring to keep the systems safe. So it's being aware of, where are the trade-offs occurring? Are we getting to, a combination of unsafe trade-offs, etc. So in essence, success and failures can both arise from individual systemic variability. And a more useful approach is understanding the continued functioning of systems under challenging circumstances rather than the searching for and rooting out of errors and mistakes. And I think what's really nice about Safety 1 and Safety 2 is the way that humans are viewed. So humans in Safety 1 are the potential liability, and we must, humans violate rules to contribute to malfunction. We need to control them. In Safety 2, humans are seen as the resource necessary for system flexibility and resilience. So work as imagined and work as done is another concept in Safety 2, understanding that there will always be a gap between work as imagined and work as done, and we can't imagine that we could create, all the policies and procedures that truly reflect all the nuances of what has to happen on the ground. So it's understanding that when we view these two things, we view them without judgment that one is right and one is wrong, but we need to critique both when we're reviewing incidents. So Hollnagel, Wears and Braithwaite note that the assimilation of Safety 2 will require new practice to look for what's going right. Don't wait for something to go wrong. Understand that adjustments are currently occurring. To focus on frequent events rather than focusing on severity. To maintain a sensitivity to the possibility of failure. To wisely balance thoroughness, efficiency, easier said than done at times, including allocating time to reflect, share experiences and learn. So efficiency in the present requires thoroughness in the past. And to review an investment in safety as an investment in productivity and understand and reconcile work as imagined and work as done. So the question is, how do we address all of these challenges? And I'll talk a little bit about sort of the concept of accountability and just culture and restorative just culture. And so essentially we think that a lot of these things can be, the restorative just culture framework does help to address some of these things, or help us build up a framework that allows a better reflection of all of these issues and hopefully learning the right lessons rather than perhaps being flawed in the way that we look at incidents. So Virginia Sharp talked about accountability, which can either be backward-looking or forward-looking. So backward-looking accountability looks to either praise or blame for actions in the past, and it holds people accountable to account for past actions, and it has a deterrence component. So that's very much sort of the traditional just culture framework is that backward-looking accountability. An alternative, which is just as valid accountability, is a forward-looking accountability, which instead looks at roles and responsibilities and processes that need to be undertaken to meet goals. It assists driving anyone who has responsibility for patient care towards actions that can improve safety, and it holds people to account for their future actions. And it's just as accountable, being held to account for learning and for improving and for healing and for supporting others is just, in some ways even a tougher process to go through than what often happens when you're looking at backward-looking accountability, where everyone just sort of often just gets defensive and no one actually is being held to account for improving the system. So the traditional just culture, David Marks talks about, it's a human-centred system of accountability, fostering open reporting, but also holding people appropriately accountable for their actions. And it looks at levels of intention. So it looks at, that there may be human error, or people may start to drift into more at-risk behaviour, taking risks that they perhaps shouldn't, or they could be reckless or actually knowingly do something wrong. And, they talk about sort of drawing the line somewhere there, that, as to whether we should sanction someone or to coach them or to accept that it was just a human error. But it's a very passive approach in many ways, that someone else is, some person in authority will work out where the line is drawn and make that decision. But there's many who would really question that. I won't talk about that slide, but so really, there's organisations are really struggling to move away from cultures of blame. And there's, if you look at the evidence, there's not a great deal of evidence that the traditional just culture approaches have led to significant improvements in culture. And that people question the ability to draw the lines between human error and at-risk behaviour and recklessness for all of those reasons that I've mentioned before about the complexity of the world in which we work. It implies that actions by staff are binary, and it fails to recognise the need to reconcile that complexity. And it also, as I said before, it's a fairly passive process. There's little opportunity or explicit embedded opportunity for engagement of clinicians, patient, or the family. So, and that forward-looking accountability looks at roles and responsibilities and driving towards actions that can improve safety. So what is restorative just culture? It asks three very different questions from the traditional just culture. It asks who has been hurt, what are their needs, and whose obligation is it to meet those needs. And really, and importantly, it's on the foundation of engagement of all stakeholders, obligations to put things right, and addressing the harms and needs. And putting things right includes looking at actions to prevent it from happening again. So moving away from those traditional models to who has been hurt, well, the patient's been hurt, the family has been hurt, but also the clinician and the organisation and the community have been hurt. So what are their needs? There is a need for support, healing, but also learning. And whose obligation is it to meet those needs? Well, there's many people with obligations across that spectrum, from clinicians to peer supporters, to the post-vention organisations, to leaders in the organisation. And some people can have both obligations and needs. So, for example, a clinician may have the obligation to support the family through connection, with post-vention support, through clinician disclosure, etc. They've got the obligation to learn, they've got the obligation to improve, but they also have needs. So we need to reconcile both. We need to address both their obligations and their needs in this framework. Now, I definitely can't read that, but this is a table that we had in our article that was published that sort of looks at, breaks it up into that, who has been hurt, well, the consumer's been hurt, what are their needs, the consumer or the family, etc. So they need support, they need healing, but they also want to be part of the learning process and the improving process. And how do we address that? We address it through clinician disclosure, and clinician disclosure, is certainly, it's not new to restorative just culture, but I think what restorative just culture helps us to understand is the why a lot of these things are important and the connection that they all have to one another. So referral to post-vention support, explicitly, what we've been able to do, is very explicitly embed, hardwire the engagement, not only in clinician disclosure and open disclosure, but engagement of the family in the review process through an interview process to gather information from them as to what they feel really happened and what they think we need to do to improve. And often, and that's, by really hardwiring that in and having it happen with every review, I think it's been a significant improvement for our service, because, we'll often imagine what we think happened, and we'll have a narrative that we understood happen, and the family will often, will not uncommonly have a very different view, or they may see something as very important as part of their experience that we didn't think was so important. So the other thing that we do in our reviews is to be open to learning on anything. We don't have to say, well, this could or couldn't have influenced the outcome. Because in suicides, often you can't say there's something that was absolutely, would have made a difference to the outcome. But you can always find something, you can nearly always find something to learn. So having that mindset of we will learn anything, and it, as I said, it's the families often, do raise issues that wouldn't necessarily have changed the outcome, but will improve their experience and the experience of consumers and families in the future. And then there's and we've also been gathering evaluation information from families as well. So the clinicians, they have the need for support and healing, and through the Always There that Diana was talking about, but they also have the obligation to learn, to improve. So, you know, fundamental, and this has taken quite a number of years in our service. We made a decision to move away from RCAs, which certainly in Queensland, the treating team can't be part of the review process with RCAs, and we've gone with a process where centrally it's the treating team who do the review with support and with a process where it's a multiple step process, and the leadership also gets involved in reviewing that material as well. And then, you know, fundamentally anyway, I'll talk through some of the learnings, and then the organisation and our review process that we've created, which we can talk about in more detail if people want to. So what are our learnings? So clinicians require a high level of trust in an organisation to engage in zero suicide aspiration and to openly learn from incidents. So trust is fostered through the use of restorative just culture framework. The negative impacts of being a second victim are significant, foreseeable, and require an urgent response by leaders at all levels of the healthcare system. Healing for all is an important consideration, and skilled staff and pathways for supporting consumers, their families, and the community following critical incidents. Restorative just culture demands actions by all and allocating roles and responsibilities for those who have a stake in the event. And that was sort of probably one of the most significant, you know, parts of the journey. You know, when we started looking at just culture, it was very difficult. You know, we read all the literature on just culture, but it was really quite difficult to work out, well, how do you go from an algorithm to actually changing the culture across the organisation? Whereas restorative just culture, you can see there are so many things that we need to do day by day that will have a tangible impact on changing culture. And, you know, encouragingly, our staff survey would support that we've actually seen that tangible change. So involving clinical teams in the review process is essential to allow the right lessons to be learned through a true understanding of work as done, everyday clinical work, trade-offs and the appropriateness of human variability in practice. Ensure involvement of staff with good understanding of recovery principles to allow for a balance between personal dignity and more restrictive processes. Greater involvement and ownership by clinical teams will facilitate translation of recommendations into actions in their workplace to make the system safer. At the end of the day, it's the teams themselves who have to bring about these changes. So having them involved in that review process, on that reflection and learning and creating the recommendations, you know, it will inevitably improve our chances of making those changes in the workplace. And ensuring service leadership involvement allows for opportunities for double loop learning, where work as imagined is overtly critiqued. So we need to critique our own work as imagined as well. Reviewing the continuum of care for consumers rather than focusing on issues proximal and leading back from an incident in a linear way helps to mitigate hindsight bias and a greater understanding of the important issues such as development of a therapeutic relationship over time. I've talked about the hardwiring of opportunities for patient and carers input, and we use tools to try to assist sort of in the review process. We use a human factors process as part of the review, but we also use the constellation diagram that tries to avoid looking at things in a linear fashion, but looks at sort of connections between issues. And we also have moved to look at a range of clinical incidents instead of focusing on a small group of severe adverse incidents. So we've done comprehensive reviews on near misses, and we review all suicide attempts that have been identified in the service, as well as look at groups of incidents, etc. So we've developed a triage process. So we meet, the leadership across the organisation meets each week to look at a whole range of incidents and then works out what would be the most appropriate way to learn from this. So as I mentioned, we've had a staff survey. So as part of Zero Suicide, you'll be aware that there's an organisational staff survey. So we did our first one about 2016, I think, and then 2017 and 2019. So in the 2017 one, we added 2 tools, the Just Culture Assessment tool and the Second Victim Experience and Support tool. And what we've been able to demonstrate between 2017 and 2019 is that we've seen an improvement in openness of communication, balance, quality of reporting processes, continuous improvement, trust and organisational support. So that's a very exciting finding, really, particularly as there are many people, there are a number of people in the literature who have argued strongly that if you introduce a zero suicide framework within an organisation, it will worsen a blame culture. What we've been able to demonstrate is you can introduce zero suicide framework in a robust way across the service and actually see improvements in your culture, but that's only if you attend to the culture, which we've done robustly as well. What we found is that staff who have engaged with the Always There program in the past rated organisational support as higher than those without previous engagements with the program. And what I think is, great correlation, that active participation in a review process of staff when they reported this is correlated with better perceptions of just culture, less second victim distress, less turnover intention, less absenteeism and more perceived support. So I think, if there's no other argument than that, which is both a workforce and an economic argument, that engaging clinicians in the review process, is a very positive thing in so many ways. So that's the presentation. We're very happy to take questions on any of it.
Thanks, Kathy. There are a number of questions that have come through. So if you look on the chat side, on the left-hand side of your screen, you'll see, how do the hot responders learn of the incident, was the first question that came through.
Okay, so we have a process where the nurse unit manager or the nurse in charge of the shift sends an email to a generic email account, and as a result of that, the next day we would mobilise a responder. So we have somebody who monitors that email address. It has taken some time. We've had to engage the wider organisation as well, and it's taken time for people to remember to do that. And what we do as a leadership group, when we see a report from the previous, for example, last night's incident report, if we don't think that the Always There has been mobilised or it's not clear that it has, we will follow that up. So we've kind of got a bit of a checks and balances as well.
Yep, and still on that, the second victim area, Diana.
Yeah. Sorry.
Go ahead.
I was going to say, really, just around the training, it was really looking to the literature. And in the slide, I identified the 5 elements that we've focused on, very heavily around psychological first aid, understanding what we're trying to achieve, obviously, and using some of the other models. But what we've done for training is that when people have volunteered to be responders, we've brought them together for a day's training that takes them through what we're trying to achieve, what their role is, and then they actually spend quite a bit of time doing some simulation, which has been very powerful. And what I think was really fascinating with the first group of responders that were trained was that the profession who struggled the most with the role of empathic listening and collegial support were our medical colleagues, our medical colleagues, because they just wanted to get right in there and fix it. Whereas the AO staff, the admin officers, they took a much clearly less clinical focus, and they just sat with the person. And I think that was fascinating, and it was great feedback for everybody. But the simulation, I think, is a very important part of the day's training.
Okay. The question about mentoring people at risk of suicide, it's not something that I've got specific knowledge about. We can talk about the time frames. What time frame did this take, and what outcomes have you seen as a result? There's a couple of questions. There's another question about how did you get executive and board buy-in? How did you get clinical governance and patient safety on board? And without either of these, what influence can a project team have? So So I think that's a great question, and so really this started probably for Diana and I even before Zero Suicide, when we were unhappy about the review processes, the RCAs. So we met with our commissioning authority who makes the decision about types of reviews, so my boss in the broader HHS, so not within our department. And we said, look, we don't think we're getting good learnings from these. We think that, when we do reviews which involve the team, there's far better outcomes. We would like you to allow us to do that. So we negotiated, that certain events we would be allowed to do this, but there was some that the commissioning authority still wanted us to do RCAs for. And I guess it's been a process that, from that of building trust from the organisation that we could actually improve the outcomes as a result of this other way of doing it. But really, with the Zero Suicide came a very intentional process of engaging the board and the executive, because ultimately we put it to them that, so we talked about Zero Suicide, and we talked about what we felt was important about it, but what the risks were. And we talked to them about the experience of losing a patient to suicide, and we talked to them about the devastating effect that it has, and we talked to them in a very frank way about the experience of our staff, that even though it wasn't their intention, that often, because, when leadership wants to know, what, as Diana was talking about, what happened, we need a report on this, etc., they often, overlook the distress and the experience of staff, and we need to do things differently. And to their credit, they took it on the chin, really, and they, accepted this feedback, and, endorsed our sort of approach. But we've been working very closely with patient safety, and we were very lucky that patient safety, usually the patient safety officers who are outside our division get allocated to various incidents, but they decided to keep one patient safety officer who would more preferentially look after the incidents in our division, and that patient safety officer was very much involved in our process of reviewing the way we're going to do these things and creating this new approach. And then was a very consistent presence. And it's great to hear her speak, because she will give an outsider's perspective of the cultural change, and she would say that it's like chalk and cheese. The way that she used to come in, people would be shut down, very hesitant to reflect and learn, to now people are much more open, and it's a much more productive process. So, so we've been able to, so it's been frank conversations, deliberate engagement of both the executive but also clinicians as well, and gradually building trust and demonstrating that we can do this. And we've had an audit process that's looked at strength of recommendations. We've had an audit process looking at quality and what we're doing, and we've been able to report on these things. Plus now the staff survey results, etc. So it's a gradual building of trust, I think.
I guess the other thing is that we've never seen this as a project. We've seen this as a whole of service culture shift or change. And I think that's really important, because as soon as we put a project in front of it, I think people think someone's going to come and do it to you, for you, and then they'll go away when it's done, and all will be well. But it's absolutely nothing like that. It's on top of your day-to-day, or our experience has been, it was on top of our day-to-day jobs, to drive this forward, to really get the staff on board with it. And I think when Kathy presented to the board and the executive, it was quite some time after we had already started the journey, really, on a soft way and within our service. So we already had quite a bit of culture change or commitment coming our way. And so it was probably a bit easier for the board as well. So I think in some ways, if I had any advice for you, I'd say do it by stealth and then go and deliver it to them.
And just about the time frame, Kathy, how long you've been on this journey since 2016?
Yeah, so probably because the conversation with the commissioning authority probably happened before that. So 2015 maybe.
2015.
And then it took us 2015. We started looking at all of this. It was really, and many people will know Sydney Decker. In terms of the just culture. We looked at all the just culture and we looked at all the evidence and all the traditional just culture, and then we had a roundtable discussion. We were lucky enough to have Sydney Decker come along, and he was just fantastic at just torpedoing all of those ideas, and really came out of that thinking, where to from here? So that must have been 2016. And then he sent me a copy of his a couple of chapters from his book and about restorative just culture, and certainly in my mind everything sort of fell into place then. You could see, but before you could not quite, as I said, you couldn't quite see, well, how does this just culture actually make a difference to the culture? With restorative just culture you could see there are so many actions that we can do now, and principles and underlying principles, and those underlying principles is something that we sort of, people will come up and ask you, or should we include this person, or should we include that person, or how do we go about this? And you can always go back to fundamental principles. Well, restorative just culture would say engagement of all stakeholders. Yes, we will include that person in this review, and we just work out how we can do that in a safe way for all.
And that is tough. We've really been, at times it's been really tough for people to think about a very unhappy family or a very, aggrieved person having a say in a review that we're undertaking. But it really, the value that it adds and the depth that it gives you, it just moves the service forward. And I don't think there's been any of our clinicians, after they've listened to the feedback, that haven't been able to really take it on board and learn from it. I think that's been one of the most important aspects.
And sometimes it can be more time consuming to do it this way, because sometimes you can see that people haven't been able to reflect, and then it's how do we set, because at the end of the day what we want as a service is to create a culture where people feel safe, where all of our staff feel that they're safe to reflect and say, gee, I wonder if we could have done things differently. And sometimes in some teams you can see, potentially there's, people aren't feeling that way. So it's then, how do we work with them to see that we can reflect and learn on things. So, and the process, although we don't do RCAs, the comprehensive reviews are comprehensive reviews for certain incidents. So it's not as if it's less work than an RCA. It's just, we think, better better work. But it can be a challenge. But we do feel that, as Safety 2 would say, spending time will save time in the future. You do need that time to reflect, to be able to learn and improve into the future. So it's an important investment in the service.
I think there's one more there about allocating the roles and responsibilities for those who have a stake in the event. Is it always, say you as the clinical director, or are there different people who would take a lead in allocating those roles and responsibilities? How does that work for you?
Yeah, so we've got sort of a sort of relatively lengthy guideline that steps out everybody's roles and responsibilities,
which we refer to. You're talking about the manifesto.
The manifesto.
We refer to it locally as the manifesto because it's so big.
So, but and I think one of the, and Sydney Decker talks about the importance of modulating our own responses to incidents so that we can learn from them. And I think one of the best things about this process that we have is that, as clinical director, I now know that we have a very robust process. I know that every Friday morning we will get together as a leadership group and we will talk about all of these incidents, and we'll think about how can we learn best from them and what sort of review should we have and who should be involved in it. And I know that there will come a time, that the team will do a review, and then there'll come a time that as a leadership group that we get to have a look at that and get to have our own reflections on it and to get to feed that back. So knowing that that's all in train, when something happens, and I also know that the leadership in that particular area, their first actions will be, as well as supporting staff, will be to check to see if there's anything urgent that needs to be done. Is there a critical, gap in the service that we need to fix immediately? And they'll let us know about that. So from my perspective, instead of the old days when I probably used to think, oh no, what's happened? Why has that happened? Who's done this? What do we need to do? And jump in and have an unmodulated response. I can now just think about, well, how are the staff? Do we have always there going to see them? How are the family? But all of that is going to be done anyway. And I know that all of those other things will happen. Right. So I think, we've got it embedded, whose roles and responsibilities everything are, but that meeting that we had, the triage meeting, so I'm involved with that, Diana's involved with that, all of our medical directors and service directors across the service, patient safety is there, our quality coordinators there, and we will all have a discussion, and sometimes it's a robust discussion. Sometimes it's about, who should be involved in the review, who would be best to bring in as a sort of a peer expert to support the team in doing this, who should co-facilitate, etc. Should we do a comprehensive review on this particular incident or not? So it can, having those sort of robust discussions. So that's how it's worked out. So there's not one of us that makes the ultimate decision. It's a joint decision really about some of those where we do actually have to make a decision about particular people involved with things.
I think that's covered off our questions. Thank you very much, Kathy and Diana. It's been very informative, and I'm sure it's stimulated a lot of thinking among the participants who've been on the webinar today. The webinar will be available for 12 months for viewing through Redback Connect, who are our hosts today. And participants who registered for the event will receive an email with a link to the webinar. So on behalf of all the participants today and the Zero Suicide Institute of Australasia, can I thank Dr. Kathy Turner and Ms. Diana Grice for their fabulous work and for being so generous in sharing your knowledge and understanding of the zero suicide healthcare approach and the importance of restorative just culture as an underpinning foundation. Thank you very much.